Okay. I'll be giving a quick presentation on this trial, the Doremi trial that came up in 2021, so last year. I've just sent out the link to the article to your email, so if you guys want, you can open it up and have a read while I'm doing the presentation, or you can do it afterwards. I forgot to send it out earlier. Just a bit of background. Let me go back. So this paper is comparing Milrinone and Dobutamine in the treatment of cardiogenic shock. And just a bit of background, there's very few randomized controlled trials comparing ionotropes for cardiogenic shock. And from my knowledge, I think this is probably the first in recent years. All the other ones are observational retrospective trials. At the moment, the European Society of Cardiology and the American Heart Association, they don't make clear recommendation on which ionotrope is better for the management of cardiogenic shock. And currently, the choice is largely dependent on clinician preference based on their idea of the pharmacokinetics or pharmacology of the inotropes. And theoretically, some people argue that Milrinone does not increase your myocardial oxygen consumption, and so potentially there's a benefit there. But this is not supported by because there's no evidence on it. This is all just it's not evidence based. So hopefully this guideline will shed light on that one. So this trial was published in the New England Journal of Medicine in 2021. It's a single-centered, randomized, double-blinded controlled trial based in Canada, and they recruited a total of 192 patients. And on the slide, you can see the research question. So basically, in patients with cardiogenic shock, they want to know whether the use of Milrinone compared to Dobutamine improves the composite outcome of all of those 6 points. So whether there's so number one is all-cause in-hospital mortality. Number two, resuscitated cardiac arrest or receipt of cardiac transplant or mechanical circulatory support, or non-fatal MI, transient stroke, or initiation of renal replacement therapy. So the important thing to note here is it's a combined outcome. So the final result doesn't show the effects of Milrinone or Dobutamine in each of those single ones. It's a combined outcome. And in terms of secondary outcomes, there's loads of them, but here are the main ones. So they're looking at all-cause in-hospital death, length of ICU stay, receipt of non-invasive or invasive mechanical ventilation after randomization. And also in terms of the safety, they are looking into whether there were any differences in arrhythmias that required medical team intervention. So setting-wise, it's a single cardiac ICU in Canada, and the trial was done from September 2017 to May 2020. And the inclusion-exclusion criteria on the slide. So they included all patients with cardiogenic shock on SCAI stage B, C, E, or E. I've got a slide later on to show what those stages mean. They only included adult patients and only patients with acute cardiac ICU admission. They excluded pregnant patients, excluded anyone that's unable to consent for ethical reason, and they also excluded patients where the clinician preferred one particular inotrope and didn't want to use any others, and also excluded all patients with out of hospital arrest. So this is basically the kind of the new definition of cardiogenic shock. So it's now kind of more in a small view as a spectrum, starting from A to E to the top. So our classic kind of cardiogenic shock is step C, and then moving on to deteriorating, and then E is when it's so severe that patients experience cardiac arrest, ongoing CPR, ECMO, etc. And then you've got A and B where they're moving towards cardiogenic shock. Shall we move on? So methodology, so 192 patients recruited. There was a one-to-one allocation to either Milrinone or Dobutamine. They randomized and stratified samples based on patients' affected ventricles to avoid that being a confounding factor. The trial was double-blinded, so all the treating physicians, patients, investigators, and outcome assessors were blinded, except bedside nurses. And it was analyzed on an intention to treat basis. In terms of statistical analysis, they designed the trial to have 80% power to detect a 20% difference between the two groups, with a two-sided alpha level of 0.05. In terms of the Milrinone intervention, this is how they dosed it. They split into 5 stages, and the consultant or the doctor treating the patient and adjust it based on their clinical judgment. And same with Dobutamine, they again split the dose into 5 stages, and again the consultant can titrate that based on clinical judgment. So this table shows the baseline characteristics of the participants. They were largely similar. I can't see one that stands out to me unless anyone here finds something they think will obviously will change the result. But I've highlighted the previous myocardial infarction bit. 41% of patients in the Milrinone group had a previous MI compared to only 30% in the Dobutamine group. I don't know if you guys think that would have affected or impacted on the result. Maybe it's something you guys can let me know, or we can discuss later on. But that's the only thing that I think really stands out to me. In terms of results, primary outcome, they found no statistical difference, but bear in mind that they were only designed to capture a 20% difference, and there was no significant difference in secondary safety outcomes. So this is a summary of the results. So from the top, you can see that there's no statistical difference in primary composite outcome, and in terms of the secondary outcome, again, all of them shows no statistical difference. So, and this is a subgroup analysis. The investigators try to analyze it based on different subgroups and see if that made a difference. And again, no difference were found between the two groups in any of the subgroup analysis. They also did a time to event analysis on the primary composite outcome and death. Again, there's no significant difference between Milrinone and the Dobutamine group. It looks pretty similar on the graph as well. And this is the secondary safety outcomes in terms of arrhythmias and hypertension. Again, there's no significant difference between the two. So discussion-wise, discussion is from my point of view, most patients in this trial was in class C and D, and so we can only generalize the results to those patients in that classification. And also, it's important to bear in mind that this was a single center randomized controlled trial in Canada. I don't know if anyone's worked in Canada, but I don't know if the practice over there in the UK is sufficiently different enough that'll make the generalizability of this results poorer. And also in terms of selection biases, this trial excluded any patients where clinicians thought that one inotrope was better than the other. To me, that's a big selection bias, and it could have excluded patients that was that could have benefited in the Milrinone group, or maybe in the Dobutamine group as well. And finally, the trial was only powered to detect a 20% difference. So any small differences, this trial is underpowered to detect. So if anything less than 20%, this trial would not show it. And so that was one of the limitations of this RCT. And in terms of pharmacokinetics, this wasn't mentioned in the paper, but this is my view, is that Milrinone is renally clear and has a long half-life, around 2 to 3 hours. So I'm not too sure practically whether this is something that you want to use over Dobutamine if the results show that there's no difference. And in conclusion, the RAINY trial shows no benefit with Milrinone, and looking at pharmacokinetics and the safety data, I don't think there's any strong incentive to change practice locally based on efficacy and safety. In this unit, I tend to see Dobutamine. I think some consultants would change to Milrinone in some cases, but mainly we use Dobutamine here. And based on this trial, I see no reason why we should change that. So that's just a summary of the trial from the paper. Any questions or anything that you guys want to discuss?
Was a good presentation. Anyone has any doubts with regards to their personal experience, especially while using Dobutamine or Milrinone, or both of them?
Do we commonly use Milrinone in our unit at all? Not really.
I've been on this unit for 2 years. I think I've only seen it a few times. Consultants change the Milrinone. Dr. Sophie,
I'm not familiar with Milrinone really. Does it have any chronotrop positive effect like Dobutamine has?
I don't think so.
Because sometimes, the only thing with Dobutamine sometimes that it's not so convenient to use when it has these chronotrop positive effect, and the patient goes with shows some tachycardia.
Yeah, but
really easy to treat with Dobutamine. So I would say I'm not familiar at all with Milrinone.
So
Does it have the same effect?
They can both cause arrhythmias, and in this trial, though, they show no difference.
No difference regarding.
But this is based on the trial.
And yes, obviously the duration of the 2 to 3 hours, as you said, half-time.
Yeah.
That would be not very easy, convenient to use in the ICU setting.
So,
but really, I'm not completely confident with using it.
Apparently, it's a minimal effects on chronotropic activity.
It's for one specific. Mainly the peripheral vessel constriction.
Based on my practice in the past, I can give some points about Milrinone. Like Milrinone became very popular in the early 2000 and 2010, and at that time it was labeled to be non-arrhythmogenic. However, there is a paper in 2015. If I get it, I'll try to share it. Which also mentioned that there is a risk of arrhythmias with Milrinone because ultimately it is also working at G-coupled protein receptor, which is the same receptor on which all sympathomimetic drug acts. So at that time, they had warned that Milrinone at higher doses, if I'm not mistaken, they have specifically mentioned above zero point 0.7 is highly arrhythmogenic, or rather as arrhythmogenic as dobutamine. And there have been trials that have compared dobutamine with Milrinone. So, and because there is no survival benefit over dobutamine, they said that many trials concluded that there is no perfect or ideal inotrope, and Milrinone is also not an ideal inotrope, which we used to think, yeah, as before. But few things, definitely they have specifically mentioned that Milrinone benefited with RV dysfunction in the early stages, not in the later stages. Tony, you have mentioned that they included patients belonging to category E of heart failure, which are as good as patients requiring CPR. So if we were to exclude category E as well and analyze on these other three categories, then definitely the trial could have shown some effect. And Tony also rightly pointed out that there was certain clinician decision which were biased of using a particular inotrope. However, they have not mentioned the reason for the bias, like why was the personal preference for one particular inotrope over the other.
Yeah, and that's the issue I have with this trial as well, because if the consultant in this trial, if they were able to pick between Dobutamine and Milrinone, then at least, tell us why, what your reasoning is, then we can learn from that as well. But they didn't. It was just excluded.
Even from severe LV dysfunction point of view, Milrinone did not give any added benefit. But from RV dysfunction, it does show a good offloading. So that is how I can recollect from the older studies. So does anyone have any other suggestions or input about this?
Okay. Should we move on, Amir?
Yep.
And I've just got one more short one about the yellow bags. I know I presented